We are very happy to be back with all of you. Hope you can hear us loud and clear. This is Caroline. I'm your host. And as you can see, Dr. Elias Tsakos is with us. Hello, Dr. Tsakos. How are you? It's great to have you back for sure.
Hi, everyone. Good evening from really hot Greece. We have 22 degrees at the moment, and it's
Nice.
9 in the evening. So let's hope the good weather will boost our spirits and give us a very good and useful webinar tonight.
Definitely. The topic tonight is definitely interesting. I know this is a topic that you always like to talk about. And of course, we will talk about robotic surgery. Dr. Tsakos has a presentation on this particular topic, but don't worry. The time for your questions will be after the presentation. As always, you can put those in the chat section. Dr. Tsakos will definitely help you with those. In case you haven't been through a webinar with Dr. Tsakos, let me just mention that he is our expert. He has been with us many times before, and he's been supporting European Fertility Society from the very beginning. So we are always very happy that you are back with us and you can share your knowledge with us here. And of course, let me just mention that Dr. Tsakos is medical director at Embryoclinic in Thessaloniki, as Dr. Tsakos already mentioned, very hot one right now. And remember that this is going to be recorded. And if you would like to have any questions, go ahead. You can type those in right now or later on. But also remember, there is opportunity for you to simply get in touch directly with Dr. Tsakos and his team at Embryoclinic. And I'm sure that they will be more than happy to help you with any questions you might have. Not only on reproductive surgery, but this is our main topic tonight. And I'm really looking forward to it. I know that this is something that you love to talk about, Dr. Tsakos. So I guess we can go ahead with the presentation, right?
Absolutely.
Brilliant. Thank you so much then. And let's go.
All right. Good evening again. Thank you for giving me the opportunity to talk to you about one of my passions. And this is fertility surgery, and in particular, robotic surgery. So could you please share my presentation, Caroline? Brilliant. Thank you very much. So what is fertility surgery? I will discuss a little bit about the history, the IVF evolution, the scientific evidence of IVF versus fertility surgery, the fact that commercial drive has favored IVF over the last 30 years or so. And also there's a medical drive that has made fertility surgery a little bit obsolete in the last couple of decades. And also the patient drive. I mean, most patients, they prefer to have IVF as opposed to having surgery. And this is a little bit of an issue because it doesn't allow us to make a complete and valid diagnosis. For example, we are very quick in making the diagnosis of unexplained infertility without performing a laparoscopy or a hysteroscopy. And just based on history, and sometimes just a HSG without a hysteroscopy and all that. So there's a lot of reasons why fertility surgery has lost its place, in my opinion, in fertility care. And also, in my opinion, especially for the younger patient, the younger female patient, this is not entirely for the benefit of the patients. One other reason that I would like to expose today is the fact that although in my training decade, which was the 90s, we were trained simultaneously at fertility medicine and fertility surgery, the younger generation of fertility specialists are solely trained in fertility medicine, or generally in IUIs, IVF, endocrinology, and all that. And fertility surgery has lost its niche, if you like. And if fertility surgery is required, then this is moved outside of the scope of a fertility specialist and is moved onto a minimal invasive surgeon specialty, which is all fine, except from the fact that sometimes the point of view of the surgeon, of the minimal invasive surgeon, or the oncology surgeon who is called in to perform fertility surgery is not exactly the same as that of the fertility specialist. So there's a lot of reasons why fertility surgery has gone out of vogue. And in my opinion, there should be a balance, and there should be a balance based on evidence, and also keeping in mind the best interests of the patients. And at the end of the day, I think that a fertility clinic should be able to offer the expertise of both medicine and surgery in fertility care. Right. Okay. Now, what are the indications of fertility surgery in general? Haven't started talking about robotics yet. So indications, effectively, most of the fertility diagnosis could be treated or could be managed at least partly by fertility surgery. So unexplained infertility, we cannot make this diagnosis unless we've done a very careful laparoscopy and hysteroscopy, which is often missed or not performed. When we have mild male factor, with the mild male factor, we need to ensure that at least the diagnostic hysteroscopy and laparoscopy has been performed, and that we have excluded a mild surgically potentially correctable female factor. Tubal factors. If we want to explore further tubal factors, we need to do laparoscopy. Endometriosis, suspected or obvious. There's a high percentage of possible endometriosis in fertility patients, and more often than not, we don't really make the diagnosis until quite a few years down the line. Fibroids. We have relied on the ultrasound scan in order to diagnose fibroids. Sometimes the diagnosis can be a little bit on the gray zone. So yes, there may be a fibroid of 2 to 3 centimeters intramural, which doesn't distort the cavity, and we may judge that this is fine. And we may be missing another fibroid who may be hiding behind this, and that may be affecting the uterine cavity. And also sometimes it's virtually impossible with the 2D scan, which is the majority of the scanning technology we use in the IVF clinics. As far as I'm aware, very few and far between clinics use high resolution 3D vaginal scanning in order to diagnose correctly and accurately fibroids, polyps, uterine malformation, and so forth. And prior to IVF, in many units, including our own, especially when it comes to complex fertility patients, there may be an absolute indication for performing at least a diagnostic hysteroscopy prior to IVF. What do we do after failed IVF? How do we exclude the presence of hydrosalpinges? Do we deal about this or not, or do we just rely on history and on a high resolution scan, which we know that is not very accurate in diagnosing correctly hydrosalpinges that may interfere with implantation and the progression of a normal pregnancy? How do we manage a miscarriage? How do we include fertility diagnostic surgery and laparoscopy or hysteroscopy after a miscarriage or not? Many times we don't. And what about fertility preservation or fertility sparing? I mean, this is also part of fertility management. Transposition of the ovaries, so outside the radiation field, may be part of our fertility care in fertility preservation surgery. And what about uterine transplantation? I think that maybe in the next 10, 20 years, that could be perhaps the most complex fertility surgery that may be widely available to many units. How do we deal with that? So this is the issues that I will touch upon tonight. So all in all, fertility surgery is often and frequently indicated in fertility and is also often bypassed and not performed. So what does fertility surgery entail? A laparotomy, hysteroscopy, laparoscopy, and I will just mention now that laparoscopy could be the conventional, rigid stick laparoscopy, and the robotic laparoscopy using the latest robotic technology. Now, laparotomy is probably invalid in 2022 for fertility surgery, has been superseded by minimally invasive surgery. Why? Because it's invasive, it requires hospitalization, it requires a lot of time for full recovery, and it has been shown, there is evidence that it is associated with higher complications versus the laparoscopy. So conventional laparoscopy, a scope down the abdomen using the conventional technology. It is a minimally invasive procedure. There has been an evolution over the last 30 years or so. So better optics, better technology, better instruments, better monitors, better lights, better energy, which we use and all that. It can be an outpatient procedure. It is associated with a very quick and short recovery. However, it does have limitations. Having said that, the majority, don't get me wrong, I mean, robotics is for the minority, in my opinion, of fertility surgery. Still, the majority of fertility surgery can be performed by standard conventional laparoscopy. However, it has limitations, which include the 2D image. We don't have a sense of depth, although this could be bypassed with the 3D laparoscopy that we may use by using special goggles. The limited range of motions, because we're using straight stick instruments. The amplified tremor, even a very experienced laparoscopist, even with many thousands of procedures, the accuracy is not of that of open surgery or of robotic surgery. And it is assistant dependent, I mean, especially for lengthy operations with lots of adhesions, big fibroids, big complex endometriosis cases. There is the element of fatigue for both the surgeon and the assistant, which can be challenging for that surgery. And of course, the ergonomics for the surgeon. I mean, the more experienced the surgeon is, the older we become. And although we like to think of ourselves as fit and healthy and still young, we're not getting younger. And the bad ergonomics of laparoscopic surgery, in which we're called to work backwards, to use our elbows, to use our wrists and all that, makes some of the cases very, very challenging, even for the most experienced surgeon. Now, what's the history of robotics? It all started in 1998 with this ugly system, and now it has evolved with the latest Da Vinci system, which we have been using in the last 5 years or so. So this is the newest Da Vinci system, which is consisted by the surgeon's console. So the surgeon operates the masters by sitting in this console and also using the foot pedals and looking down a 3D magnified set of lenses. This is the patient card. These are the robotic arms, which are operating under the direction of the surgeon within the body with very high accuracy. And this is the control system with all the software, all the energy supplies, and of course the high definition monitors. So what are the advantages of the latest robotic technology Da Vinci? The fact that we work with up to 10-fold magnification, the fact that we use 3D imaging, we have high definition, we have stable camera, which is controlled by the surgeon. When we sit in the console, we have the ability of using 4 limbs. We use both our feet and our hands, and also we can control the camera and the assistant port at the same time. So effectively, we don't really need a very experienced assistant, as we can move the 4 robotic arms with all our masters and controls and foot pedals and so forth. One of the biggest advantages is, of course, the 7-degree movement that we have with this new technology, and with the dexterity that is much better than the human hand, because the degree of freedom of the wristed instruments is much better than the human hand. And of course, there's no tremor, which is also very important. So these are the main advantages. And of course, we don't need an experienced assisted surgeon, which means that we spare one person for the rest of the team to look into the patients from a different perspective, and it is suitable for operating deep into the pelvis or in restricted areas. And of course, last but not least, the ergonomics, which ensures that we can do difficult long operations without the strain on the doctors. The well-being of the surgeon is also important, especially when we're called to work longer hours and perform at a higher level for a long time during the day and next day and so forth. There are some disadvantages of the robotic system. One is the costs. There's a debate about this because, again, it depends on how we factor all those costs. Yes, there's a bigger upfront cost compared to laparotomy. There's a bigger cost compared to conventional laparoscopy, and now we're waiting for the evidence to come out that this can be that can be counterbalanced by the benefits with regards to less complications, less chance of conversion into laparotomy, especially for challenging complex cases, for obese patients, for patients with multiple surgery in the past, with complex pathology, with severe endometriosis, big fibroids, and all that. So this is debatable. Yes, the upfront cost is there, but now there's a big movement towards trying to use perhaps less robotic arms, to use less expensive consumables and all that in order to bring the cost down. And of course, if we compare that to IVF, and if we compare, if we manage to achieve through surgery spontaneous conception, then of course that cost could be counterbalanced by the avoidance of IVF, by drugs, by the complications of IVF drugs, and so forth. At the moment, there's no tactile feedback from tissues and sutures. However, with experience, we do get visual feedback. It's still a bulky machine, although the more you look at it and the more you use it, the less bulky it looks, miraculously. There is a locked position of the patient cart, which is not a challenge so much for fertility patients, because we can direct the robot into the pelvis. Even for challenging cases with big fibroids or with adhesions in the upper part of the pelvis, we still get away without undocking. But if we do need to undock, the newer systems are giving us this opportunity. And of course, one other main disadvantage is that there's limited availability at the moment in terms of hospitals offering this service, systems in various hospitals, and of course trained surgeons. So what's the comparison between the Da Vinci system versus laparoscopy? We use in summary, we're talking about advanced technology, multi-arm system, and precise surgery. What are the indications? Tubal Re-anastomosis. I would like to explore a little bit more this area. I have to remind to the audience that IVF was partly discovered because of our inability to restore the tubes especially after tubal ligation, which, as we all know, has been a method and still is a fairly recognized method of family planning. So if somebody changes their mind, and a good proportion of the females change their mind, or they go through a divorce, or they, for some reason, they want to regain their fertility, and tubal anastomosis with the Da Vinci system could be a viable option, and in either case could be discussed, not just IVF. Robotic myomectomy, especially for challenging big fibroids, complex fibroids, multiple fibroids, in difficult patients with morbid obesity, perhaps, or with previous multiple surgery. Endometriosis, especially severe complex endometriosis, could be, in my opinion, better managed by robotic surgery. And also ovarian cysts, big ovarian cysts, challenging ovarian cysts, where it is important to ensure not only that we remove the ovarian cyst effectively, but that we also preserve the ovarian reserve. Pelvic adhesions can be challenging. Sometimes we don't have access to the ovaries for IVF, and therefore we need to do adhesiolysis in order to move an ovary into an area that would be accessible with the vaginal scanning in order to do the egg collection and all that. And of course, cervical cerclage, abdominal cervical cerclage in case of cervical insufficiency. And finally, fertility preservation and ovarian transplantation could be indications for robotic surgery. Now, tubal re-anastomosis, in my opinion, this is a very challenging new area, new perhaps niche area for the application of the robotic system, since maybe 25 to 35, maybe 1/3 of our patients have tubal factor infertility. Of course, not all tubal factor infertility can be surgically corrected. Another figure is that maybe a quarter of the patients regret of having a tubal ligation. In my opinion, those patients should be counseled and offered the option of robotic re-anastomosis. And of course, that decision would be made based on various factors. And here, the robotic surgery has shown some advantages and may bring this technique back into vogue. The first robotic tubal re-anastomosis was performed in 1999, and of course in 2000 that was also performed, and in 2013 there was a very important paper in Human Reproduction showing that it is safe and effective. And there is a very nice publication in 2014 showing that just with one stitch technique using the robotic system we could achieve roughly 6% pregnancy rate, which is pretty high and very nicely comparable to the best of IVF clinical results. And again, there has been publications in 2017. Lots of studies involving more than 10,000 women showed that in sterilized women, surgical tubal re-anastomosis is an effective treatment. And with robotic surgery, a new era is rising. So this is a take-home message. Do not forget that this is also an option. Fibroids, very quickly, very common, usually benign tumors, although a very tiny proportion could be malignant, so be aware. They could grow on the surface of the uterus, they could grow deep inside the muscular layer, they could grow in the cavity, and of course their importance depends on the position and also on the size. Myomectomy is widely performed in fertility care for various reasons. If there are symptomatic fibroids or fibroids impinging the cavity, or growing fibroids, or multiple fibroids, or big fibroids, and so forth. And laparoscopy has been proven to be superior to laparotomy overall, and that has been clearly established. Robotic myomectomy, there has been evidence, and there's a lot of studies proving this, that there's less blood loss and shorter hospital stay versus laparoscopy. Although still, I repeat, still, in this day and age in Europe, as far as I'm aware, still a good proportion are still performed by laparotomy. Laparoscopy is perhaps the golden standard, in my opinion, at the moment. And if laparoscopy is not possible because of various complexities, then robotic should be another valuable option. We wouldn't do a robotic myomectomy for 4-centimeter fibroid that's touching a little bit the cavity and all that, perhaps. But if we have multiple 4-centimeter fibroids or larger fibroids or complex patients with medical history, with obesity, with previous surgery and all that, in my opinion, robotic is superior as it is to laparoscopy, as it is associated with less blood loss and shorter hospital stay. Now, the operating time has has been reported to be longer. However, I debate that. That was with the use of the previous system and perhaps with less experienced surgeons. I'm hoping that some teams, including ours, should be able to publish soon that this is not the case anymore, that we take less time than with a laparoscopy. And with regards to cost, as I said, there is a debate depending on how you define the cost overall. If you factor in the complications, the potential for open surgery with complex laparoscopies, and also the blood loss and its complications, the return to work and all that, my feeling is that maybe the cost is comparable with better outcome for robotics. Endometriosis is very common. Up to 50% of infertile women practice committees that it's a chronic disease and it requires lifelong management. This is 1 in 10 overall of women. So 1 in 10 of women in the overall population. It could be as high as 50% infertility, and some of it is undiagnosed. This is a very medical diagram which is indicating all the guidelines of the scientific societies and of course of the place of surgical management, which is very, very important in some cases. And Da Vinci versus laparoscopy, similar results, longer times, not enough numbers, still using the previous system. And again, the challenge lies on our shoulders and the newer generation system with the newer generation teams, hoping to prove that maybe for some cases, some subgroup of endometriosis, robotic may be superior. Fertility sparing surgery, these are rare cases. I'm not going to spend a lot of time on that. And again, we're talking about the cancer patients. We're talking about patients who are aiming to preserve their fertility. Robotic surgery has a very valid place here. At the moment, similar results, although the trend is towards robotics, as it has been in urology, for example. Ovarian transposition also important, and Da Vinci has been shown to be efficient during oncology surgery. And here are some rare cases of ovarian tissue transplantation and the outcome, and still an experimental method, but the trend is positive at the moment. And in 2016, there was a very important publication on the first live birth after ovarian transposition. What are the future prospects? In my opinion, uterine transplantation would become more and more common in the next decade or so, and robotics may play an important part in that, either in retrieving the specimen or in transplanting the specimen, or both. Single port robotics, this is becoming more and more popular for various reasons. There is a single hole in the umbilicus. And of course, we're waiting for the next generation of robotic platforms with the use of haptic feedback, the 3D vision, and of course, the artificial intelligence assistance. So in conclusion, robotic fertility surgery is a minimally invasive type of surgery. Robotics has enhanced our vision, objective and metaphorically, of surgery. It has the potential to contribute significantly in fertility surgery. Robotic surgery and gynae robotic surgery is here to stay. And further studies, of course, are required in order to compare current robotic platforms, because until now, we don't have enough studies on the latest robotic technology with current conventional laparoscopy, because laparoscopy is evolving as well. Technology is evolving as well. Laparoscopy will still be the gold standard. It's like, airlines and jets and airplanes are not here to replace the cars. Cars are still going to be many more, and car journeys are going to be many more than flights, perhaps. But depending on the destination, if I would like to make a metaphor here, we may be able to choose what's the best way to travel safely, with safety and effectiveness. And in my opinion, again, and I'm not just an enthusiast, I mean, there's 10 million robotic procedures overall that have been performed globally at the moment, not just in gynecology, but overall. So robotics is here to stay. and in my opinion, it will acquire an established place in modern fertility care. So that's another challenge for the fertility specialists, and also, of course, for the minimally invasive gynecological surgeons. This is my hometown. This is beautiful Thessaloniki. You're all invited to come and visit us, whether you're patients, colleagues, doctors, nurses, midwives, whoever you are, administrators in the fertility world. It would be our pleasure to show you around our city, our civilization, our culture, and of course our technology in both fertility medicine and surgery. And this is a small group of my team that have helped me bring together this presentation. Thank you so much for listening, and I'm all ready for questions. Thank you.
As always, brilliant. Thank you so much, Dr. Tsakos, for presenting this particular topic. And as always, you've been thorough with everything here. And well, now your favorite part is about to start. So remember, you can put all the questions in the chat section. Dr. Tsakos will definitely help you out. There are some questions ready. So don't hesitate if you have something that you would like to ask. This is your time. And let's have a look. The first question is ready. It's quite a longer question. So let's have a look. Christina, thank you for your question. So nice to see you again. My question is in relation to hormone therapy, right? Replacement therapy. My doctor has put me on. I am a bit worried about taking estrogen and progesterone together. It's called cycloprogenova, especially that my doctor asked me to take it for 21 days, then wait for my cycle to come, then take it again on the 19th of my cycle. It's a lot, and I am concerned about side effects, increased breast cancer risk. I have a family cancer risk for breast cancer. I wanted to ask, what do you think about this? Does HRT actually help in IVF cycle? My periods have started to be irregular, hence why I think my doctor has put me on them. Is it another way to avoid HRT?
Okay, thank you, Christina. I mean, firstly, as a principal, I don't like to give an opinion without, full knowledge of your case and your history, your particular details and all that. And my general advice also is that, if you trust your doctor, just go on with the advice. If you don't, find someone you trust. But in general, if I were to give my general opinion, is that with regards to breast cancer, in my opinion, at the moment, there's enough evidence that IVF or a short course of HRT is not associated with increased breast cancer risk, provided that you have been thoroughly checked. I mean, I don't put anyone on HRT unless I have a recent, within maximum 1 year, full assessment of their breasts. So mammography, breast ultrasound, and then HRT or IVF. If that's the case, then there's absolutely no risk in taking the HRT for a short period of time prior to IVF. Now, the second comment is that if there is indeed a family breast cancer history, that has to be thoroughly evaluated. There are specific algorithms which would tell us if you qualify for genetic screening or not. If I want to give you an example, I mean, if your mother had breast cancer at the age of 60, probably you're not at higher risk because of genetics. If your grandmother had breast cancer at the age of 50 or 70, probably you don't have any risk. However, if you have one or two members of your family, your immediate family, with breast cancer, colonic cancer, ovarian cancer that has developed before 50, then you may be at high risk because of genetics. Please remember that only 5%, 1 in 20 breast cancers are genetically linked, and the other 95% are totally not associated with genetics. So bottom line, if you're concerned about family history, have a proper assessment by a geneticist or by a breast specialist in order to identify if you are indeed in high risk. You may find that you're not, but if you're on the gray zone or if you're on high risk for family breast cancer due to the history, then go on and have genetic screening with BRCA1 and BRCA2 in the first instance.
Brilliant. Thank you so much for your advice, Christina. I hope that you feel much more confident right now. Thank you so much indeed. And there is a thank you from Christina for your answer right here. Okay, and let's have a look. Sima has another question. My question is, how long should one wait post-poly removal and frozen embryo transfer? Is 4 or 5 weeks efficient?
Absolutely is the answer, Sima. Easy answer. Absolutely. I mean, effectively, women have an amazing self-healing mechanism in place, and this is called the menstrual period. So, yeah, 4 to 5 weeks is absolutely fine. Now, if I would like to make a little comment, if the polyp is too big, if there's any concern on the hysteroscopy, if there's any reason for a little bit of worry whether the healing is complete or not, or if there's any adhesion formation, or if there's a little bit left over of the polyp and so forth, then maybe an office diagnostic hysteroscopy may be in order before you proceed to frozen embryo transfer. But in my opinion, that is an exception. Now, polyp is only 2 centimeters. 2 centimeters is a huge polyp. It's not, if it's 2 centimeters. If it's 2 millimeters, it's a small polyp. May I make a little comment here that the lining, the entire lining, the entire endometrial area is probably about 2 centimeters. So 2 centimeters is not a small polyp, it's a big polyp. Discuss with the doctor. Again, that has to do with the findings in hysteroscopy. Also, it has to do with the stem of the polyp. Was it a broad-based polyp or a thin-based polyp, and all that. So generally 4 to 5 weeks is fine, but if there's any concern, then please do have a diagnostic hysteroscopy, no anesthesia, just a little flexible tube into the uterus to ensure that healing is 100%.
Perfect. Thank you. And as you can see, Sima has added, thank you very much. Operation is Friday. So
best of luck.
Exactly. Sure. Thank you so much, Sima, for your question. If you have any more, you know what to do. And we did receive one more question from Maria here. I did the EMA test and had an abnormal microbiome and took antibiotics. Shall I do another EMA test before next transfer? My doctor suggested instead of a test, just to take antibiotics for transfer. Just in case, what are your thoughts?
I would probably agree with your doctor 100%, to be honest.
Okay.
Yeah, you've done the treatment. EMA test is highly accurate. I'm sure you took the right antibiotics based on the profile of the results. That would suffice, plus an extra dose prior to the transfer would do the trick. You'll get pregnant.
Perfect. Thank you so much, Maria. And there's a thank you for you right here. And well, I'm just waiting because for now there are some comments saying, thank you so much, very, very well presentation. There's another one, thank you for detailed presentation. I'm just looking out to see if there are any other questions. If you have, you know what to do. If not, I'm sure that you can just simply get in touch with Dr. Tsakos and his team. They will be happy to help you with more details, I'm sure. Yes, we have a comment. So as you can see, Sima has added such an amazing presentation. Thank you once again. Most definitely one of my best ones I have attended. Glad to hear that, Sima. Thank you so much for that. And I'm just waiting for some more comments or questions. Someone is typing, so let's give it a minute and see if we do have more questions. Still, someone is typing. Let's give it a minute. I need to wait a bit to see it. And in the meantime, perhaps I can just show you where to get in touch with Dr. Tsakos and his team if you wish to do that. There is a link and there is also a contact button there. You can do that. And in the meantime, we did receive one more question from Maria. This is more generally IVF related, but in my last egg retrieval, only 2 embryos could be sent for testing. And last year with another clinic, I had 6 and 9. Could it mean that my new clinic isn't very good, or is it other reasons?
I'm sorry, Maria, I can't really answer this. I mean, basically, again, if I can make a little comment, is that, usually we don't expect this huge variation from one year to the other. However, there may be some factors that I'm not aware of. For example, some general health issues, some other associated factors, sometimes a COVID infection, or some sort of hidden endocrinology disease, maybe some hidden thyroid disease and all that. So I don't think that I can answer this. I would look into the protocols that they have followed. I mean, in general, if any clinic, in my opinion, I mean, the first thing we do is we look into the previous stimulation, and if we're happy with the outcome of the stimulation compared to the profile of the patient. So, say for example, we got 6 eggs out of a 39-year-old. Are you 43 years old? I mean, put it this way: 2 embryos is more towards normal for a 43-year-old than 6 or 9. So I'm not sure. I mean, the first thing we look at is the previous protocol, and if the previous protocol has produced good quality eggs, we usually don't change it. And again, we have to factor this against the background characteristics of our patients and all that. So I can't really answer the question. And again, another factor is which embryos does every clinic deem as judges as normal. Last week we created 6 blastocysts out of a 43-year-old, but only 2 of them were good quality in order to risk performing pre-genetic testing on them and so forth. So again, very tricky question. I can't answer. I'm sorry.
That's understandable, of course. Thank you so much, Maria. If you wish to get some more details, I'm sure it's possible. Dr. Tsakos would just need probably more details as well. So you can get in touch with them directly as well. I'm just waiting. Someone is typing, so let's give it a second again. I need to see whether it's a question or a thank you. Okay, Maria has some more details here. That answer still helped a lot. Thank you. If doing another, then we'll ask to use the old protocol. Okay. Thank you so much, Maria.
I mean, if I can just elaborate a little bit from this case, I mean, it is very important, and to be honest, I'm pleasantly surprised by how much input we have from our patients over the last 5 to 10 years. Before that, before 2010, very few patients that I recall had an idea of what's going on, of the protocols, of the drugs, of what's the optimum stimulation. Very few patients knew that we give the final maturation injection when the leading follicle is 18 or 19 millimeters and so forth. So what I find, and I think this is partly, if not fully, because of resources like yours, Caroline, like the European Fertility Society, our patients are so well educated, and this is amazingly helpful, not only for the patients who can challenge us and who can contribute into their own treatment, but it's also very educational for us as well, because we get such good historians. They give us such wonderful evidence from previous cycles. They give us input. They give us all the tools, and a lot of tools that we didn't have before, in order to treat them in the best possible way. And also, indirectly, we interact. I mean, I get a lot of education from my educated patients, because by looking into previous protocols, previous approaches, previous beliefs, if you like, of doctors, of nurses, of midwives, administrators, I think we're getting better. And I would like to thank everyone for this. I would like to thank the contributors to this education. I would like to thank the European Fertility Society for the opportunity not to educate only our patients, but also us. I mean, I have to confess that I'm listening to a lot of your webinars. I have learned a lot from my wonderful colleagues and webinars, and I think we're all getting better. And if I want to conclude this, I would like to say that, one of the reasons, perhaps one proportion of the bigger success, the IVF success we have achieved in the last 5 years, is not just the technology, it's not just the medications, it's not just the protocols, it's not just our approach, it's also this this fact that we're dealing with highly educated patients. So thank you so much for this.
Thank you so much indeed. You've been a part of this, as I've mentioned, from the very beginning, and we are very happy to be able to share the knowledge with everyone through webinars, but of course, and of course, thanks to all the experts that are here every single week as well. So thank you so much for that. And in the meantime, we did receive one more question from Christina. Let's have a look. I have been taking DHEA 50 milligrams for about 3 months, and when I tested, my DHA levels were 420, and which seems a lot. Is it normal to raise to this much in just 3 months? My doctor asked me to stop supplementing.
Difficult again, Christina. You got me there. I mean, basically, I probably agree with the doctor. Although, to be honest with you, I don't usually. Well, you've been taking 50 milligrams once a day or twice a day. That's another question. Or 3 times a day. But to be honest, generally,
once a day.
Yeah. Once a day. I don't know. I'm a little bit skeptical if this can be increased so highly by just. I mean, the standard dose, as you probably know, is 2 to 3 times a day, but of course for less period of time. So I would probably agree with your doctor. Although I have to confess that I invariably do not test for DHA levels because it's very difficult to interpret and associate this with any benefit or any alteration of the management. And also, I invariably do not give DHA for longer than maybe 6 to 8 weeks prior to stimulation. And if I do, I give a double dose. So again, we have a lot to learn about DHA. There's quite a few projects going on at the moment. We're hoping that in ESHRE in July, we should be able to listen to some results about the optimum duration, the optimum dosage, and the optimum type of priming, of androgen priming prior to stimulation, whether it's going to be DHEA or testosterone. So I would probably agree with the doctor and just hang in there until we have some more evidence as to what is the best way to prime your ovaries prior to stimulation.
Okay, thank you so much. And Christina has added, how long can I wait after these tests before I do the IVF again?
To be honest, I wouldn't wait too long. Because the longer you wait, this effect may wean off, and therefore, if there is a potential benefit, that would be with maybe higher doses of higher levels of DHA circulating in your body. So maybe just carry on the IVF in the next month or so.
Okay, sorry, I missed one question from Christina here. Okay, so let me just have a look. To do hysteroscopy and microbiome, is it the best thing to do before going for IVF after failure of the IVF transfer?
Probably yes is the answer. But again, to be honest, I'm a big fan of hysteroscopies. I mean, I think that hysteroscopy is not a big deal. I mean, we can do it without anesthetic. We can do it with mild sedation. I think that it should be part of standard baseline fertility workup. I mean, 30 years ago, laparoscopy and hysteroscopy together used to be the norm, used to be the gold standard for the workup. Now, we don't do that many diagnostic laparoscopies anymore. I think we're losing a lot of endometriosis by not doing it. What is the effect of that on our success rate and our complications? I don't know, but there may be a small component there and miscarriages. So yes, if you had a failed transfer, I think it would be indicated to have a hysteroscopy and microbiome check. Yes.
Okay, understood. Thank you so much indeed for yet another question. Looks like that was our final question. So thank you everyone for joining us, for your questions. I believe it has been useful and helpful. Remember, there is always an option for you to get in touch with Dr. Tsakos. And of course, as you know, there are more events coming up. Next week on Tuesday, we are back with another topic, anonymous versus non-anonymous egg donation. So if you haven't signed up yet, you can go ahead and do it. And of course, as you can see, Dr. Tsakos, many thank yous are coming up your way as well. So thank you so much indeed. It's always great to have you as our presenter and expert, of course. So Yeah. Anything else you would like to add before we finish tonight?
No, thank you very much, and keep up the good work. I'm looking forward to your next webinars. As I say, I learned a lot from them,
Glad to
and
hear this for sure.
have a lovely evening. Hang in there, and just keep going. And I'm very sure that all of you will succeed at the end. Just hang in there and be optimistic, positive, and strong. Thank you very much. Good night.
Thank you very much indeed, and I hope to see you soon, very very soon here. I mean, and of course, everyone have a lovely evening, and of course, we will be back for sure. Take care. Good night. Bye.
Good night, everyone. Thank you. Bye bye.